Hi everyone, it's Kara. I'm back to talk about during labor what we call the Cascade of Interventions. So these are processes, they are procedures that may occur in order to help move a labor along. And we're going to talk a little bit about what they are so that you know if you hear these terms what they mean. This does not excuse and should not replace a provider explaining them to you, giving you what we call BRAIN. The acronym BRAIN stands for the benefits. So BRAIN, BRAIN. The benefits, R, the risks, A, the alternatives, I, the information, also your intuition. So they've given you the benefits, the risks, the alternatives, and the information. What is now your intuition telling you? And what happens if we do nothing? So keep that in mind as we talk about the cascade of interventions when it comes to entering labor and delivery. So let's ask ourselves first, when should somebody receive an intervention? So when do we go forward with this? The answers are a few. If you want to receive an intervention, you should get it. And it won't cause harm to you or the baby. If you want that intervention, you should receive it. If there's an emergency. So if you are unable to give your consent or like there's an imminent threat to your survival or baby's survival, they may opt to give you an intervention because there may not be fully time to communicate what life-saving measures are being offered to you. But if it is not a true emergency, if this is not a life-saving measure, and there is time to explain what is happening, they are required. This is not optional. They are required to explain what they would like to do next and offer you the benefits, the risks, the alternatives, the information, and you are then able to ask your intuition whether or not you would like to do that. And if you would not like to do that, what happens if we do nothing? They need to be able to provide you with that information. So this brings us to the Cascade of Interventions. And we call it the Cascade of Interventions because it moves in oftentimes like a more linear form from least invasive to most invasive. And one intervention can lead to another. It doesn't always, but it can. So when you are getting really close to term, they may be like, okay, it's about time for you to start kickstarting labor because baby's ready to come out. And they may offer what they call a membrane sweep. Membrane sweep is when a provider takes a gloved finger and basically circles the inner edge of the cervix, which separates the sac, which we like called, when you hear someone's water breaking, that is their membranes, their sac rupturing, and that helps stimulate the release of the prostaglandins, which is a hormone that helps jumpstart labor. If that does not jumpstart labor, you're not offered a membrane sweep before you are offered a medication called Cervidil, which is a medication that softens the cervix and promotes the release of prostaglandins, you can ask for the membrane sweep before the Cervidil. The Cervidil is usually provided in a vaginal suppository, so it's inserted inside the vagina and allowed to sit, and it should start to slowly progress into labor. You should start to feel contractions and labor moving along with the Cervidil. If that does not happen, they may offer you what's called a Foley balloon catheter. So a Foley balloon catheter is inserted into the cervix and inflated, and that helps to expand the cervix to 3 centimeters of dilation. So once we get the cervix to 3 centimeters of dilation, the goal is to have the body and the hormones take over to start progressing to the full 10 centimeters that we need to pass the baby through the birth canal. If that does not happen, they may offer you Cytotec. So, and if they offer you Cytotec before they've offered you a Foley balloon catheter, and you're thinking, I actually want to try the Foley balloon catheter before we move to the Cytotec, that is an option that is available to you. So the Cytotec, also known as misoprostol, which some of you may know or have heard of because it's also the same medication that we use for medication abortions, is a medication that will stimulate contractions. And so by stimulating contractions, you're starting the process of jump-starting labor. You're really like getting the uterus to start moving baby towards the birth canal, which will start positioning baby to thin out the cervix to reach the full 10 centimeters of dilation, and then to get the baby into a station where your uterus can push the baby out. That is one stage. The next stage would be Pitocin. And Pitocin is synthetic oxytocin. So we've talked about in previous videos that oxytocin is a hormone that is oftentimes known outside the birth world and in the birth world as a bonding hormone, but oxytocin also stimulates contractions, and stimulates contractions in the setting in the uterus to push out baby. Pitocin can be really, really intense, so can Cytotec, because you're basically going from like a 0 or like an early stage of labor to 10 like all at once. And it moves very quickly, and so does the escalation of discomforts, because your body is going through a lot of change in a very short period of time without as much time to adapt. Pitocin is usually administered through an IV at a dose that is started out lower and then might move up, or I say might move up, but if you are in extreme discomfort, it is within your right to ask them to slow down the administration of Pitocin, the dosing of Pitocin, or turn it off. I've had doctors in the labor and delivery room, when I've said this to a patient, say no, they can't, or not advise it. That goes back to the brain acronym. What are the benefits? What are the risks? What are the alternatives? What is the patient's intuition saying? Do they want more Pitocin? Do they not want more Pitocin? And what happens if they don't? What happens if we don't change the level of Pitocin that they're at? Patients have their own autonomy. You have your own autonomy and right to dictate your own care. And if you say no more, like, I need a break, I don't want any more Pitocin, I need like time, if they cannot provide you with a solid explanation, it is not an emergency, your no is a complete sentence. They do not need to continue with Pitocin. So if we've gone through the stages of Pitocin and your water has not broken, they may do what's called an artificial rupture of the membranes. So what that means is that they go in and they manually, they use a tool to break your water. the benefits of this is that, you know, you're getting closer, you're preparing to go into labor to meet baby. The reason why somebody might not want that is because once we rupture the sac, once we rupture the membranes, you're opening up the uterus and the womb to potential infections. This isn't always a bad thing. I just want to put it out there because there's a reason why some people might say no or not want to. Might want to let their water break on their own. So unless there's a lot of complications or like valid concern, electing not to have it is something that is within your right. There are measures that we can take once the membrane has been ruptured, just like any other labor and delivery, to try to minimize and prevent any risk of infection. So minimizing the number of cervical checks or interventions moving forward that involve inserting things into the birth canal or into the cervix to minimize the potential for bacteria or other pathogens to enter in there is a way that we can do that. We're gonna jump into an epidural. So these ones kind of step off of the cascade of interventions because they, like an epidural may have already happened before you get a Pitocin. An epidural is a combination of medications and anesthetic that is injected into the spinal cord. What's really important to know is that sometimes epidurals take multiple sticks to place. You have a right, if somebody has tried to stick you multiple times and cannot get it, you can ask for a new anesthesiologist. You do not have to stick with the one that's there trying to deliver the medication. It's also important to know that sometimes, even though they may not get it on the first time, or they may get it on the first time, it may not numb you completely, or it may only numb you on one side. So making sure to like have your body rotated so the medication can distribute evenly, knowing that it may not block out all of the pain are important because sometimes we expect it to take away all the pain to numb us from the waist down, which is why you won't be able to get up out of bed like unassisted once you've had an epidural, or move around quite as freely once you've had an epidural. That is an intervention that is mostly available to you unless you have reached a stage of labor where you're unable to sit still for it to get placed. And then lastly, the last intervention that I'm going to talk about in the cascade of interventions is a C-section. Again, this one may not follow that linear trajectory. And this by no means, when I talk about the linear trajectory, we've talked about how sometimes they may not offer you one and you can ask to go back to that. Or you can say, I actually want to skip ahead. I don't want to like take a slow path through labor. I want to really like get things moving. That's within your right. It goes back to when should you receive an intervention? When you want that intervention, and when it's safe to receive that intervention. So a C-section, somebody might elect to have a C-section. That might be somebody's plan A. We oftentimes talk about in the planning phase of the perinatal period, the prenatal period, that the C-section is like a last resort. And for some people, it is. C-sections do come with their own series of risks. It is a major abdominal surgery, but it can also be a life-saving measure. So we have this cascade of interventions oftentimes to minimize the risk of resorting to a C-section. And sometimes C-sections are resorted to with like undue risk assessment. Sometimes it's literally just that providers are like, oh, this, especially in a hospital setting, that this birthing person is taking too long to progress through labor. And so we're going to move to a C-section. Sometimes it's that we've gone through all of these cascading interventions and there's signs of fever or infection, or the birthing person is just fatigued, like you're just exhausted and you can't push anymore, you can't do it anymore, baby's not in position, baby's not moving into the right station, there's not enough effacement or dilation, and like we all agree, the birthing person and providers agree that a C-section is on the table. But like I said, that birthing person might say, you know, I just really want a C-section. It's also important to note that just because you've had one C-section doesn't mean that you can't deliver in a pelvic birth or a vaginal birth later on. There's a procedure that's called a VBAC, which allows you to have a pelvic delivery or vaginal delivery once you've already had a C-section. C-sections, also a reason why somebody may not want them, aside from it being a major abdominal surgery and having a longer healing time, which could pull them away from work, kids, other responsibilities. Maybe they just really want to be home, back reunited with partners or family. It also can delay like bonding with your child. Sometimes you're not always able to hold baby right after having a C-section and initiating a latch. So these are all like things that folks can really have strong feelings about, really grieve. It can be a difficult process, especially if it was not your top option to move through all of these options and end up at a C-section or an intervention that you might find a little bit scary or unnerving. And I want to validate that because it is really personal and there's a lot going on and your body's going through a lot. So trust yourself. Remember brain, benefits, risks, alternatives, information and intuition, and what if we do nothing? And I hope that this gave you the information that allows you to feel more confident in making decisions when you enter that birthing space. Love you, trust you. Drop any questions, feelings, comments, information in the chat, in the comments below, and we'll see you soon. Thanks.